Okay, let's unpack this. We are diving deep today into what is arguably one of the most critical yet often missed diagnostic intersections in modern medicine.
Hmm.
We're talking about the connection between the head, the neck, the ears, the domain of otorhinolaryngology, or ENT, and these really complex multi-system inflammatory diseases.
Things like connective tissue disorders and the primary vasculine.
Exactly. Our mission today is, I think, ambitious, but absolutely essential. We want to understand why a seemingly localized symptom, a recurring mouth ulcer that won't heal, or sudden
Oh, you
hoarseness,
just chronic sinusitis.
right, why that can be the critical Rosetta Stone, the first foundational clue that unlocks a much bigger, much more dangerous diagnosis.
A multi-system illness that, if you leave it untreated, can cause severe morbidity and even mortality.
So we're here to create a kind of blueprint for connecting those isolated ENT symptoms to the vast landscape of systemic inflammation.
And that analogy of the Rosetta Stone is it's perfect because these rheumatological disorders are the ultimate masqueraders.
They can look like anything.
They can look like anything.
Yeah.
By their very nature, they are multisystemic. Their symptoms overlap so extensively that they can mimic common, localized conditions that an ENT specialist sees every single day.
Simple infections, allergy.
Exactly. Simple infections, minor trauma, allergic reactions.
Yeah.
But the stakes couldn't be higher. A mouth ulcer might be let's say, a benign diagnostic clue in systemic lupus erythematosus, or SLE.
Okay.
But that same kind of structural involvement in a different disease can be a rapidly unfolding, life-threatening emergency.
Okay, when you say a life-threatening emergency manifesting in the ENT area, what specifically are we talking about? What's the real clock is ticking scenario?
The most immediate, the most urgent concern is acute arthritis of the crico-arytenoid joint.
Okay.
Now, this joint is tiny, but it's vital for controlling the movement of your vocal cords. If that joint becomes rapidly inflamed, say, in a flare of rheumatoid arthritis or juvenile idiopathic arthritis,
Right.
the vocal cords can just cease to function. They can become immobilized, causing vocal cord dysfunction and massive stridor, which is severe airway narrowing.
So the patient can't breathe.
The patient cannot breathe.
Yeah.
And that requires immediate intervention, potentially intubation. Another urgent scenario is the rapid tissue destruction you see in an active vasculitis, like granulomatosis with polyangiitis or GWP.
Formerly known as Wegener's granulomatosis.
Correct. There, the inflammation can cause laryngeal stenosis, restricting airflow over a very short period.
So this means the diagnostic pressure is just immense. If a patient comes in with, say, persistent nasal crusting or chronic sinusitis that just won't respond to treatment, the ENT specialist can't just focus on the nose. They have to zoom out.
Absolutely. They have to perform a comprehensive internal medicine review. The key to an accurate assessment and to avoiding these dangerous treatment delays is meticulous systemic screening.
A full review of systems.
A full review of systems and a general examination to spot that second or third presentation, the thing that confirms the systemic nature of the illness. And the reverse is also true.
How so?
Well, any physician or pediatrician examining a child for systemic symptoms, like an unexplained fever or joint pain, has to ensure a comprehensive ENT assessment is performed. They need to be looking for those mouth ulcers or any parotid gland swelling.
Because if you miss that second piece of the puzzle, the persistent fever alongside the nasal crusting, you delay the critical step.
You delay seeking expert consultation. And we are talking about diseases with high morbidity and mortality. Early and accurate diagnosis is everything.
And it's about pattern recognition.
It's all about clinical pattern recognition. It's the constellation of symptoms, not just one isolated sign that really counts. That's why the expert opinion of a rheumatologist or a pediatric rheumatology team must be sought as early as possible.
To stop the patient from getting weeks or months of unnecessary local treatment.
While the systemic disease just continues its destructive path on the kidneys or the lungs or the central nervous system.
That really sets the stage. So now that we understand the necessity of this holistic view, let's get into the details. Let's talk about the actual spectrum of ENT presentations. What are the earliest structural clues we might find in the head and neck?
Okay, let's start with localized articular involvement. So, the joints. There are 3 specific areas in the head and neck that are really vulnerable to inflammation in these diseases.
And those are?
The temporomandibular joints, or TMJ, the cervical vertebrae in the neck, and that crucial crico-arytenoid joint we just mentioned.
How does arthritis in the TMJ present? Is it like the pain you'd get in your hand, or is it more of a mechanical issue?
It's both, really. In the temporomandibular joint, the inflammation causes local pain, sometimes referred pain, and restricted movement. It can make chewing very difficult.
Okay.
But the presentation in the cervical spine is perhaps even more alarming, especially in chronic inflammatory conditions, like rheumatoid arthritis or juvenile idiopathic arthritis.
Why is that?
Because the inflammation or even secondary osteoporosis from the disease or its treatment can lead to erosion or even collapse of the vertebrae.
And what would a patient or a clinician actually see if that happens? What are the signs?
Well, it can manifest as torticollis, which is a twisted or tilted neck, especially if the onset is in childhood.
Yeah.
Or you might see clear neurological signs because of cervical cord impingement,
Like loss of movement.
loss of movement, abnormal sensations, things like that. We also see secondary effects like dysphonia, hoarseness, or even vocal cord paralysis, which are linked to the mechanical damage or erosion of those cervical vertebrae.
So the structural damage in the neck has immediate functional consequences for speaking and breathing.
Immediately.
Yeah.
And beyond the bone and joints, there's the distinct pathology that involves the cartilage itself.
And when you say cartilage, what disease immediately comes to mind?
You have to immediately consider relapsing polychondritis. The classic, highly specific, or what we call pathognomonic sign of this disease is chondritis of the pinna.
The outer ear.
The inflammation of the external ear cartilage. It'll appear red, swollen, extremely painful, but the earlobe, which doesn't have cartilage, is often spared. And that little detail helps differentiate it from a simple infection.
But the threat of relapsing polychondritis isn't just cosmetic, right? It attacks all cartilage.
Exactly. This is a rare episodic autoimmune disease that causes a progressive inflammatory destruction of all types of cartilage throughout the body.
All types.
All types. The elastic cartilage, like in the ear and nose, the hyaline cartilage in the joints and the tracheobronchial tree, and the fibrocartilage in the axial skeleton. When it attacks the trachea and bronchi, it leads to chronic inflammation, malaise, and potential collapse.
Which would cause stridor and breathing problems.
Yes, and ultimately respiratory failure. This is why systemic immunosuppression is absolutely mandatory. It's a life-saving intervention.
Okay, let's pivot to scleroderma, or systemic sclerosis. We often think of it as skin hardening, but how does the localized form morphia affect the face and mouth?
Localized scleroderma can be quite disfiguring. It can present with marked skin thickening, dyspigmentary changes, changes in skin color, and even hemifacial hypertrophy.
Where one side of the face looks different?
Yes, one side of the face appears larger or structurally different. That's a syndrome known as Perry-Romberg syndrome. We also see gum retraction and sometimes even involvement of the tympanic membrane, the eardrum.
And in the systemic form?
In the systemic form, the stiffening of the soft tissues leads to what's called sclerodermatous facial pinching and a severely decreased mouth opening. And as we'll discuss later, that is a major, major concern for airway management and anesthesia.
This is where those structural changes lead directly to functional problems. Now let's move to some of the most frequently encountered clues: mucosal and glandular issues. Why are mouth and nasal ulcers such huge red flags for a specialist?
Ulceration is a massive diagnostic sign. We immediately think of two main diseases, Behçet's disease and systemic lupus erythematosus.
And the key is telling them apart.
The differential here is crucial. SLE ulcers, which you find on the palate or the buccal mucosa inside the cheek, are characteristically painless.
Painless, that's the key.
That's the key. And they can be the very first sign a patient reports. Behçet's ulcers, on the other hand, are typically intensely painful. They're recurrent, and they're often accompanied by genital and perianal ulcers.
So that simple question, is it painful, is a critical first step.
It's a critical step toward directing the laboratory workup.
And what about the patient who repeatedly comes in with a sore throat, but their swab is always negative for strep?
That patient is demanding a deep dive into autoinflammatory and autoimmune conditions. A sore throat or pharyngitis can be the presenting symptom in acute rheumatic fever, systemic onset juvenile idiopathic arthritis, and also in dangerous conditions like macrophage activation syndromes or MAS.
And hemophagocytic lymphohistiocytosis, HLH.
Correct. And those last two are often these hyperinflammatory states that are secondary to an underlying rheumatological or even a malignant condition.
And of course, there are the more benign but highly recurrent periodic fever syndrome.
Yes, PAAPA syndrome, which stands for periodic fever, athostomatitis, pharyngitis, and adenitis. It's the most frequent recurrent fever syndrome in childhood.
And it's diagnosed clinically.
It's diagnosed clinically. It involves tonsillitis, fever, ulcers, and it requires differentiation from the more serious genetic periodic fever syndromes, which we'll get into later.
Okay, let's talk about dry mouth or xerostomia. It seems like a symptom that's very easy to dismiss as just dehydration or age.
It is, but it's often tied to a major inflammatory condition. Xerostomia is a defining feature of primary and secondary Sjogren's syndrome.
And Sjogren's can occur on its own or with other diseases.
Exactly. It can be a standalone disease, which we call primary, or it can be secondary to almost any other major autoimmune disorder, like SLE or rheumatoid arthritis. And along with the dryness, we often see salivary gland enlargement, particularly of the parotid glands.
You also see that in sarcoidosis, right?
You do. But in Sjogren's, there's a pediatric difference in presentation that's really important.
Okay, what's that?
While adults typically present with the classic dry eyes and dry mouth, in childhood, recurrent parotid gland enlargement is actually the most frequent presentation of Sjogren's syndrome.
So for a child with puffy cheeks that come and go, you have to think Sjogren's.
You have to. And clinicians need to recognize this early, partly because Sjogren's carries a very serious long-term risk.
And that risk is?
People who are diagnosed with Sjogren's syndrome are at a significantly increased risk. We're talking up to 44 times the risk of the general population of developing non-Hodgkin lymphoma.
Wow.
Specifically a type called mucosa-associated lymphoid tissue, or MALT lymphoma. And this is why rigorous lifelong surveillance is necessary and why that early diagnosis is so critical.
The head and neck area is just a dense highway of cranial nerves. When we look at the neurological manifestations, which nerves are most commonly affected in these systemic diseases?
The trigeminal nerve, cranial nerve 5, is frequently implicated. Dysfunction can occur in Sjogren's syndrome, systemic sclerosis, SLE, and mixed connective tissue disease.
And the symptoms?
They can range from sensory disturbances to facial pain. We also see peripheral facial nerve palsy, what might initially be mistaken for a standard Bell's palsy complicating Sjogren's syndrome, and sarcoidosis.
And hearing loss, whether it's sudden or gradual, that's a major signal that something systemic is attacking the microvasculature.
That's the critical mechanism right there. Hearing disturbances can be caused by an autoimmune neuropathy, meaning the body is attacking the 8th cranial nerve itself, or by vasculitic damage to the vasa nervum, the tiny blood vessels that supply the auditory nerves. And this often presents as sudden sensorineural hearing loss.
So what are the conditions that should immediately come to mind when a patient presents with unexplained sensorineural hearing loss?
Well, the list is long, which reflects just how many conditions cause microvascular inflammation. You have to think about SLE, granulomatosis with polyangiitis, relapsing polychondritis, polyarthritis nodosa, and the highly specific Sjogren's syndrome.
Sjogren's as well.
Sjogren's syndrome is also implicated, yes. And while it's less frequent, eosinophilic granulomatosis with polyangiitis and Banseth's disease can also cause hearing loss. It's also important to note that many of these, especially GWP, can also cause a conductive hearing loss from middle ear inflammation or eustachian tube dysfunction.
Okay, let's circle back to the biggest fear factor, airway emergencies. When a patient develops stridor or airway narrowing, you mentioned crico-arytenoid arthritis. Can you describe that clinical scenario? How quickly does it escalate?
A patient with an existing inflammatory joint disease, maybe rheumatoid arthritis or ankylosing spondylitis, might initially just complain of some pain or hoarseness. But if that crico-arytenoid joint flares, the swelling can be incredibly rapid.
And they present how?
The patient will present with severe shortness of breath, a high-pitched inspiratory noise, that's the stridor, and often panic. This is an immediate high-grade emergency.
Because the vocal cords are stuck.
The vocal cords may be fixed in the midline, preventing effective breathing. And we see this mechanism in RA, ankylosing spondylitis, juvenile idiopathic arthritis, and even in gout.
So if a patient with known RA starts complaining of sudden voice changes or difficulty breathing, that joint has to be the first suspect. What about the non-arthritic causes of stridor?
Mucosal inflammation and swelling are common culprits. We see this in active vasculitis like GWP or Churg-Strauss or in SLE. The inflammation leads to tissue swelling that physically narrows the airway. Less commonly, we might look for extranodal mucosal disease like lymphomas, which can mimic these inflammatory symptoms.
And neuromuscular causes like myasthenia gravis.
Yes, myasthenia gravis causes a fluctuating muscle weakness, and that includes the laryngeal muscles. This can present as vocal cord weakness and dysphonia that gets worse with effort, And in a rare but important scenario, newborns can get neonatal myasthenia
How
gravis.
does that happen?
It's due to the transplacental transfer of anti-MuSK antibodies from a maternal autoimmune condition, and it leads to weakness and feeding difficulties in the infant.
So hoarseness or dysphonia is clearly a common thread here.
It is. It's associated with the cervical cord changes we discussed, osteophyte formation or vertebral erosion in conditions like JIA, which can affect the nerves controlling the vocal cords. It can also be a direct result of tissue deposits on the vocal cords themselves, like in sarcoidosis.
And finally, let's categorize the issues with swallowing or dysphagia. This is another major functional impairment.
We can categorize swallowing issues by the root mechanism. First, there's muscle weakness or myopathy, which we see prominently in dermatomyositis and polymyositis, as well as myasthenia gravis.
Okay, weakness is one.
Second is physical constriction. An example would be esophageal strictures due to the fibrosis and tightening that happens in scleroderma.
And the third?
Third is motility disorders, where the esophageal muscles just don't contract properly. And these functional motility issues have been reported in dermatomyositis, polymyositis, systemic sclerosis, and SLE, and they can affect both the upper and lower esophagus.
The range of these ENT symptoms is, as you said, staggering. But the patient rarely offers up just one clue. They come with a constellation. This leads us to our next crucial step, the systemic red flag checklist.
Exactly. This is the non-ENT review that has to accompany every examination to connect that localized clue to the systemic disease.
So we've covered the nose and throat. Now we look below the neck. What are the general constitutional signs that should immediately trigger a high level of suspicion?
We start with the simple constitutional symptoms that the patient often reports kind of vaguely. Things like joint pain, stiffness, especially early morning stiffness that lasts for more than 30 minutes, and joint swelling.
And the more general signs.
Crucially, we look for unexplained fevers, general malaise, a debilitating tiredness or fatigue that doesn't get better with rest, unexplained weakness, and unintended weight loss. When these symptoms accompany that localized ENT finding, the systemic nature is almost confirmed.
And revisiting ulceration, the scope needs to be broader than just the mouth and nose.
That's right. The patient has to be asked specifically about genital and perianal ulceration. If a patient reports oral, nasal, and genital ulcers, particularly if they're recurrent, that combination is nearly pathognomonic for Behçet's disease.
Okay, let's dedicate some time to the skin because it's the most visible system. The rashes associated with these diseases are like specific fingerprints. What are the must-not-miss cutaneous markers?
First, we look for the photosensitive malar erythema seen in systemic lupus erythematosus. This is the classic butterfly rash, but the defining feature is that it characteristically spares the nasolabial folds.
That detail is key.
That detail is key for differentiation. Then there is the salmon pink, fleeting urticarial rash, a hallmark of systemic onset, juvenile idiopathic arthritis. We also look for psoriasis, of course, which can overlap with inflammatory arthritis.
And what do we look for to identify the small vessel vasculitis hitting the skin?
That would manifest as purple or black ulcerated vasculitic rashes, which indicate small vessel damage. Other generalized rashes can include skin ulceration, which can be painful, and erythema nodosum.
And that presents as nodule.
Yes, as tender, red, warm nodules, usually on the shins. Erythema nodosum can be a sign of sarcoidosis or a secondary reaction to an infection, like a streptococcal infection.
You also mentioned specific signs of hardening and fibrosis associated with scleroderma and myositis.
Yes, in systemic sclerosis, we look for sclerodactyly, the thickening and tightness of the skin of the fingers, and the characteristic sclerodermatous facial pinching. For dermatomyositis, the unique clue, the facial appearance.
A heliotrope rash.
Exactly. Puffy eyelids, often with a heliotrope, violaceous or purplish look around the eyelids. That discoloration is highly specific.
And what about the subtle vascular changes that you can see right on the hand?
The nail fold capillary changes are critical. Using a small microscope or even just a simple magnifying lens, changes in the capillaries at the base of the nail can suggest underlying microvascular damage.
And which diseases show those changes?
These changes are highly suggestive of systemic sclerosis, dermatomyositis, and SLE. We also look for alopecia or hair loss, which may be scarring or non-scarring. That's often a feature of active SLE, sometimes accompanied by scalp rashes or ulceration.
Shifting to vascular and major organ involvement, the consequences of systemic inflammation in these systems are often what drive morbidity and mortality.
Cardiovascular features are definitely prominent. We screen for Raynaud's phenomenon, the episodic pallor and color change in the fingers on cold exposure, which signifies microvascular spasm.
And on a larger scale,
We check for general hypertension. And in the case of large vessel vasculitis like Takayasu, we look for loss or diminution of peripheral pulses, or even the presence of peripheral aneurysms. Internally, we check for pericarditis, endocarditis, and myocarditis.
the blood system is also under attack, often resulting in a hypercoagulable state, a high-risk clotting state.
That's the domain of antiphospholipid syndrome, or APS, which can be a primary disease or secondary to conditions like SLE. APS causes thromboembolic phenomena, clots in the veins or arteries, and recurrent miscarriages. Finding signs of clotting requires immediate intervention.
Moving down the body, what about respiratory symptoms? What should concern us?
Chronic cough, shortness of breath, and signs of restrictive lung disease are all common. We're looking for interstitial pneumonitis and pulmonary arterial hypertension, which are very serious complications frequently seen in SLE, scleroderma, and dermatomyositis.
And the kidneys, which are often a silent target in many of these conditions.
Nephritis is a major life-limiting consequence, particularly in SLE and the ANCA-associated vasculitides. It presents as hematuria and proteinuria, blood and protein in the urine renal impairment, and hypertension. A simple urinalysis is a mandatory screening tool.
The central nervous system involvement is notoriously varied and often difficult to diagnose.
The neurological features are broad and often vague. You have neuropathies, myopathies, and direct CNS involvement. This can manifest as debilitating headaches, a reduction in intellectual function, psychosis, or loss of memory.
All classic signs in something like active SLE.
Yes, or primary central nervous system vasculitis. We also have to scrutinize ophthalmological disease, uveitis, retinal vasculitis, and retinal vein thrombosis, all of which require immediate expert eye care.
That systemic checklist is exhaustive. Now, let's pivot to the definitive evidence, the laboratory features. Before we get into specific autoantibodies, what are the general inflammation markers we rely on?
The basic markers are often the first sign. You're looking for a raised erythrocyte sedimentation rate, or ESR, and/or a C-reactive protein, or CRP. These indicate systemic inflammation.
What about blood counts?
We look for cytopenias, low counts of red or white blood cells, and sometimes thrombocytosis, which is an elevated platelet count, as part of the acute phase response.
And if there is muscle damage?
We check for raised creatine kinase, or CK, and lactate dehydrogenase, or LDH. We also look for other general markers like raised ferritin, which can indicate uncontrolled inflammation, sometimes rising to dangerously high levels in conditions like macrophage activation syndrome. You might also see raised immunoglobulins and abnormal thyroid function tests due to overlapping autoimmune conditions.
Okay, now let's get into the specifics. These autoantibodies are the molecular fingerprints of the disease, starting with the ultimate example, systemic lupus erythematosus.
The foundational test is for positive anti-nuclear antibodies, or ANA, which is highly sensitive but not specific. The truly definitive fingerprints are the extractable nuclear antibodies, or ENA, specifically anti-Rho, anti-Long, and anti-Smith. But the most specific marker for active SLE is anti-double-stranded DNA, or anti-DS DNA. High titers of anti-DS DNA often correlate with active kidney disease or nephritis.
And for scleroderma?
Scleroderma typically shows a positive ANA alongside highly specific antibodies. These include positive anti-centromere antibodies, which are often associated with the limited cutaneous form of systemic sclerosis,
Okay.
and positive anti-Skil-70, also known as topoisomerase antibodies, which are usually associated with a more diffuse and severe form of the disease.
For the vasculitides, you mentioned the key marker earlier.
I did. A positive anti-neutrophil cytoplasmic antibody, or ANCA, test is highly suggestive of vasculitis. And these are further broken down into proteinase 3, or PR3 ANCA, which is associated mainly with GWP, and myeloperoxidase, or MPO ANCA, which is associated with microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis.
What about sarcoidosis? Is there a blood test for that?
Sarcoidosis often features a raised serum angiotensin-converting enzyme, or ACE. However, this is not a perfect marker. We have to remember that a raised ACE is non-specific.
What else can cause it?
It can also be seen in conditions like Hodgkin disease, diabetes, alcoholic hepatitis, and hyperthyroidism. So ACE levels must always be interpreted in the context of the clinical picture and ideally a biopsy showing non-caseating granulomas.
And finally, Sjogren's syndrome.
Sjogren's syndrome is typically characterized by a positive ANA and positive ENA, especially anti-Rho and anti-lag. Finding this constellation of laboratory features when you pair it with chronic dry mouth, parotid swelling, and those systemic red flags strongly points toward the diagnosis.
That laboratory synthesis is the final step in establishing suspicion. Now we move into section 3, focusing specifically on the vasculitides. We established that the classification of vasculitis, the inflammation of blood vessels, is crucial because treatment hinges entirely on the size of the vessel involved.
That's right. The classification system is absolutely essential for guiding therapy. It separates the diseases based on the size of the blood vessel, large, medium, or small, the presence of granulomatous histology, ANCA positivity, or there's immune complex deposition. We need to detail this structural breakdown now as it forms the backbone of recognizing these conditions.
Okay, let's start at the top with the largest vessels.
The predominantly large vessel vasculitis involves the aorta and its major branches. This group includes Takayasu arteritis, which is seen mostly in younger women and causes diminished peripheral pulses, and giant cell arteritis.
And that one affects older adults.
Yes, it's the most common primary systemic vasculitis in adults over 50, often presenting with headache and jaw claudication.
Okay, moving down to the arteries that feed the organs.
Now we have the predominantly medium-sized vessel vasculitis. This includes polyarteritis nodosa, which can affect medium-sized arteries throughout the body. We also see childhood polyarteritis nodosa, cutaneous polyarteritis, and of course Kawasaki disease.
Which, as we noted, is the most common childhood vasculitis, and is so dangerous because of its ability to cause coronary artery aneurysms.
Exactly.
The small vessel vasculitides are often divided by their histology, particularly the presence of those inflammatory masses, the granulomas.
Correct. The predominantly small vessel vasculitis granulomatous group includes two major ENT threats: granulomatosis with polyangiitis, or GWP, and eosinophilic granulomatosis with polyangiitis, EGPA, which is also known as Churg-Strauss syndrome. GWP is characterized by those destructive granulomas in the respiratory tract.
And the non-granulomatous small vessel diseases.
That's a large, diverse group. It includes microscopic polyangiitis, Henoch-Schönlein purpura, or IgA vasculitis, which primarily causes a purpuric rash, arthritis, and sometimes renal disease.
What else is in that group?
We also include craiglobulinemic vasculitis, which is often secondary to other CTDs or hepatitis C infection, and anti-GBM disease, where the immune system attacks the glomerular basement membrane in the kidney and the alveoli in the lung.
And what about the diseases that don't fit neatly into a single size category?
Those are the variable vasculitides. This includes Cogan syndrome, defined by its eye and ear involvement, and Behaus disease, which can attack vessels of any size, from tiny capillaries right up to the major vessels of the aorta.
And finally, the other category.
The classification also includes other vasculitides, which are usually secondary to underlying issues like infection, drugs, or malignancies, or those that are associated with established connective tissue diseases like SLE or rheumatoid arthritis.
This detailed structure is vital, but let's focus now on the specific vasculitides that cause the most dramatic ENT pathology. We have to start with Kawasaki disease.
Kawasaki is the most critical vasculitis of early childhood, affecting medium-sized arteries. The diagnosis is entirely clinical, which means we rely solely on pattern recognition and the checklist.
And the requirement is a persistent fever for at least 5 days.
Plus 4 of 5 specific features.
Let's list those 5 features again and detail their presentation.
Okay. 1, changes in the extremities or perineum, so you'd see swelling or redness of the hands and feet. 2, a polymorphous exanthema, which is a generalized nonspecific rash. 3, bilateral conjunctival injection, which is often a non-pus-producing aseptic conjunctivitis.
And the ENT clues.
4, changes of the lips and oral cavity. This is the ENT clue. You get severe injection of the oral and pharyngeal mucosa. And 5, cervical lymphadenopathy or swollen lymph nodes in the neck.
The oral impact sounds severe.
It is. The mucosal inflammation causes the classic strawberry tongue, a swollen red tongue and lips, severely cracked lips, and inflammation at the corners of the mouth angular stomatitis, which can be so painful it prevents the child from swallowing. It can sometimes be mistaken for Stevens-Johnson syndrome.
And we must emphasize the life-threatening risk associated with Kawasaki.
Yes. The acute risk is myocarditis. The long-term risk, which is why the diagnosis is so urgent, is the formation of coronary artery aneurysms, which can lead to a heart attack later in life.
And treatment is standardized.
It is urgent and standardized. Intravenous immunoglobulin and high-dose aspirin, which significantly reduce the risk of aneurysm formation.
Next, granulomatosis with polyangiitis, or GWP. This disease is known for its incredible destructive capacity in the head and neck.
GWP is a necrotizing granulomatous vasculitis that primarily targets the upper and lower respiratory tracts, as well as the kidneys. In the ENT sphere, it is absolutely synonymous with destruction.
So what specific ENT signs should the specialist be hunting for?
Chronic rhinosinusitis that is often non-responsive to antibiotics, leading to bloody discharge and persistent nasal ulceration. The inflammation specifically targets the nasal cartilage nasal chondritis, which leads to the classic structural collapse, that saddle nose deformity.
And that damage is irreversible.
It is irreversible. We also see laryngeal stenosis, severe chronic sinusitis that can destroy the bony walls of the sinuses, and sometimes orbital involvement causing proctosis or bulging of the eye.
Our sources provided a strong visual illustration of this progression. How does that help us understand the disease?
That visual aid is crucial because it demonstrates the continuum of destruction. It shows that in the early stages, the nasal mucosa is just angry and hypersecretory, and it's often dismissed as a simple infection.
But the advanced stage?
The advanced stage demonstrates the gross destructive activity, severe crusting, ulceration, and damage to the underlying structure. The clinical takeaway here is that you cannot wait for the saddle nose deformity to appear. You must diagnose and treat in the inflammatory phase to prevent that irreversible destruction.
And the lab clue for GWP?
This is a proteinase 3 ANCA positive disease. In the generalized active phase, 90% of patients will be PR3 ANCA positive.
But there's a catch.
There is a critical diagnostic trap. In the localized phase, when the disease is confined primarily to the nose or lungs, only about 50% of patients are positive. Therefore, a negative ANCA test never rules out early or localized GWP.
Given its high mortality, how intensive is the required treatment?
It's extremely intensive. GWP requires urgent high-dose steroids and potent immunosuppressants like cyclophosphamide or rituximab to induce remission, sometimes combined with plasma exchange for severe kidney or lung involvement. Milder or localized disease can sometimes be treated with maintenance therapy like methotrexate, but that induction phase has to be aggressive.
Now, eosinophilic granulomatosis with polyangiitis, the former Churg-Strauss syndrome, what is the classic triad?
Asthma. Hypereosinophilia, a markedly elevated count of eosinophils in the blood and pulmonary, infiltrates with eosinophil-rich granulomatous inflammation. This disease is a combination of allergy, asthma, and severe systemic vasculitis.
And the ENT presentation here is often related to allergies.
Yes. The hallmark in the head and neck is severe, non-responsive allergic rhinitis, chronic sinusitis, and nasal polyps. This combination, especially when it's accompanied by adult-onset asthma and high blood eosinophils, should immediately trigger suspicion for EGPA.
And the ANCA status?
About 40% of patients are ANCA positive, usually with anti-myeloperoxidase or anti-MPO specificity.
Moving to Behçet's disease, which is defined by its recurrent mucosal symptoms. What are the strict diagnostic requirements?
Diagnosis relies on the central requirement of recurrent oral ulcers, at least 3 times in a 12-month period, plus 2 or more of the following features.
Okay, what are they?
Recurrent genital ulcers that typically scar, ocular inflammation like uveitis or retinal vasculitis, specific skin lesions like erythema nodosum or pseudofolliculitis, or a positive pathergy test.
Can you describe the pathergy test?
The pathergy test assesses skin hyperreactivity. A sterile needle stick, which would normally heal without incident, causes a specific inflammatory papule or pustule to form 24 to 48 hours later. It's a sign of the body's highly reactive inflammatory state.
And how does Behçet's affect the ear?
Audiovestibular involvement is significant. Sensorineural hearing loss, or SNHL, is reported in up to a third of patients. It's usually bilateral and affects high frequencies, and it's thought to be due to vasculitis of the cochlea's microvasculature.
So they can also get dizzy.
Yes. Patients also experience recurrent vertigo, bilateral Meniere's syndrome, and instability due to vestibular dysfunction.
And what about confusion with other conditions?
Well, the oral ulcers can be confused with common canker sores, but they are often multiple, deep, and highly recurrent. Crucially, oropharyngeal ulceration may be misdiagnosed as simple tonsillitis. And we have to remember the highly inflammatory condition known as MAGIC syndrome.
What is that?
It's the rare overlap of Behçet's disease with relapsing polychondritis. It stands for mouth and genital ulcers with inflamed cartilage.
Let's discuss Cogan syndrome, which is defined by its tightly linked eye and ear symptoms.
Cogan syndrome is defined by two features: ocular symptoms, specifically non-syphilitic interstitial keratitis, and audiovestibular symptoms that mimic Meniere's disease, sudden tinnitus, vertigo, and a rapid, gradual hearing loss.
And there's a time limit.
Yes, the strict classification requires that the interval between the onset of the eye and ear symptoms be less than 2 years.
What happens if the presentation is atypical, or if the symptoms are separated by a long time?
If there's a delay of more than 2 years between symptoms, or if the classic inflammatory ocular manifestations are absent, it's considered an atypical Cogan's presentation. Systemic features of vasculitis are often present, and sometimes anti-HSP70 antibodies are found, which may serve as a marker for the autoimmune hearing loss component. ANCA positivity can also occur.
And finally, let's just revisit relapsing polychondritis, stressing that airway danger again.
RP is rare, but its potential for destruction mandates recognition. The episodic inflammation of cartilage can compromise every system. While we focused on the pinna, the most critical internal feature is the progressive destruction of the tracheobronchial cartilage.
Which leads to airway collapse.
It leads to malaise, collapse, recurrent infections, and chronic stridor, culminating in respiratory failure if systemic immunosuppression is not initiated promptly.
We now turn our attention to the ultimate systemic disease, systemic lupus erythematosus, or SLE. If the vasculitides are defined by vessel size, SLE is defined by its ability to target virtually any cell or organ.
SLE is the quintessential multi-system inflammatory disorder. Its protein or varied presentations are why diagnosis requires specialized input. And from the ENT perspective, it's not a rare complication. Mucosal presentations occur in up to 45% of cases.
Which makes the ENT specialist highly likely to be the first clinician to see evidence of the disease.
Exactly.
Let's detail those oral lesions again, emphasizing why they are so easily missed.
They're easy to miss precisely because they are often painless. They can appear as irregular raised white plaques, sometimes with surrounding redness, or silvery white scarred lesions, or actual ulcers. You typically find them on the soft or hard palates or the buccal mucosa.
And because they're painless.
Because they're painless and non-irritating, the patient might not even mention them. Or a primary care physician might mistake them for common trauma or simple canker sores.
The differential diagnosis is vast, making that clinical suspicion so crucial.
It is wide. For any oral lesion, the specialist has to consider lichen planus, candidiasis, intraoral herpes, common aphthous stomatitis, but also leukoplakia, and even malignancy. In SLE, we also find discoid lesions on the lips, which involve inflammation and atrophy, and they can later scar into pigment.
What about lymphadenopathy in SLE? Is that a common finding?
Yes, lymphadenopathy occurs in roughly 40% of cases. The nodes are usually soft, non-tender, and discrete, and you commonly find them in the cervical, axillary, or inguinal regions.
But there's a warning here.
There is. Whenever we find persistent lymphadenopathy in the context of systemic illness, the differential diagnosis must remain high for conditions like Kikuchi syndrome, lymphoma, and leukemia. This might necessitate a tissue diagnosis if suspicion is high.
To truly master SLE, we have to understand the professional standard for its classification. We're dealing with two major sets of criteria used by rheumatologists: the newer SLICC 2012 criteria and the original ACR 1997 criteria. Why do professionals use these complex checklists?
These criteria are essential for standardizing diagnosis, particularly for research and clinical trials, to ensure that all patients classified with SLE truly have the same disease. They move the diagnosis beyond a vague clinical impression to a defined, measurable condition.
Let's break down the Systemic Lupus International Collaborating Clinics, or SLICC 2012 criteria. What is the fundamental requirement for classification?
The patient must meet 4 or more criteria, and that has to include at least 1 clinical criterion and 1 laboratory or immunologic criterion.
There's an alternative, right?
Yes. Alternatively, if the patient has biopsy-proven lupus nephritis, the most severe organ involvement, they only need to be positive for the highly sensitive ANA or anti-DNA antibodies to meet the definition.
The SLICC clinical criteria list is extensive, 11 points. Let's walk through the definitions of the most critical ones, starting with the cutaneous manifestations.
Okay, they are acute cutaneous lupus, which includes the malar rash and generalized erythema, chronic cutaneous lupus, which encompasses the scarring discoid rash, oral or nasal ulcers, and non-scarring alopecia hair loss that does not destroy the hair follicles. The distinction between acute and chronic cutaneous involvement helps reflect the varying pathology.
Moving to the systemic clinical features.
This includes arthritis, which is defined as involvement of two or more peripheral joints, requiring swelling or effusion. Sinusitis, meaning inflammation of the lining of the lungs, or heart pleuritis or pericarditis. Renal disease, which requires a specific level of proteinuria or cellular casts. And neurologic manifestations, including seizures, psychosis, or other complex CNS issues.
And the hematologic features.
We look for hemolytic anemia, leukopenia, which is defined as a low white cell count, specifically below 4,000 per cubic millimeter, and thrombocytopenia, defined as a platelet count below 100,000 per cubic millimeter.
Now, the 6 SLICC immunologic or laboratory criteria, these are the disease fingerprints we just discussed.
They are a positive ANA, positive anti-DNA antibodies, positive anti-ICM antibodies, positive antiphospholipid antibodies, low complement levels C3, C4, or CH50, as complement is consumed during active disease, and finally, a positive direct Coombs test, although this is only counted if the patient does not already meet the clinical criterion for hemolytic anemia.
That is the SLICC framework. Now let's compare that to the older but still highly referenced American College of Rheumatology, or ACR, revised criteria from 1997. Why do these criteria require more restrictive, precise definitions?
The ACR criteria historically served more as classification rules for research than strict diagnostic criteria, and that led to these highly specific definitions. For instance, the molar rash must be a fixed erythema over the malar eminences, and again, we emphasize the clinical detail. Has to spare the nasolabial folds.
And the discoid rash definition is also very detailed.
Correct. Under ACR, a discoid rash must be defined as erythematous raised patches with adherent keratotic scaling and follicular plugging, and scarring must occur in older lesions. This level of detail ensures that less specific skin lesions are excluded.
Let's look at the nuances of internal organ involvement in the ACR criteria.
The definition of arthritis is key. It has to be non-erosive, involving two or more peripheral joints. And this detail is important because erosive arthritis, where the joint surface is actually destroyed, is typically reserved for diseases like rheumatoid arthritis. SLE-related arthritis usually causes inflammation without bone destruction.
And the renal disorder definition.
Renal disorder is strictly defined as persistent proteinuria greater than 0.5 grams per day or greater than 3 plus on a dipstick, or the presence of specific cellular casts, which may be red cell, hemoglobin, granular, tubular, or mixed. The presence of those casts is highly indicative of active nephritis.
The immunological disorder section is slightly different in the ACR criteria as well.
It is. While anti-DNA and anti-SIM are common to both, the ACR details the specific definitions for antiphospholipid antibodies. This can be an abnormal concentration of IgG or IgM anticardiolipin antibodies, a positive test for lupus anticoagulant, or a false positive test for syphilis that's been positive for at least 6 months and is confirmed by a specific test like the treponema pallidum immobilization test.
So a false positive syphilis test can actually be a clue for lupus.
It's another potential key immunological clue for SLE. Reviewing both sets of criteria demonstrates just how much complex pattern recognition is required to move from an isolated mouth ulcer to a definitive SLE diagnosis.
We must now shift to the third major group of inflammatory disorders, the autoinflammatory syndromes. This is a crucial distinction. Unlike autoimmune diseases, which involve autoantibodies and targeted T cells.
Autoinflammatory diseases are caused by innate immune dysfunction, and they're characterized by recurrent flares without those high autoantibody counts.
We're talking about the hereditary periodic fever syndromes, or HPFSs. What is the defining clinical feature?
They are rare genetic conditions defined by recurrent, short, explosive attacks of fever, severe systemic inflammation, which often includes a sore throat, tonsillitis, and lymphadenopathy, and the patient returning to complete baseline health between attacks. High acute phase reactants are essential for diagnosis.
It sounds like a recurring failed attempt at diagnosing an infection.
That is precisely the clinical dilemma. The symptoms are indistinguishable from an infection, which leads to many failed courses of antibiotics before the recurrent pattern is established. They are fundamentally disorders of the inflammasome, the cellular alarm system that triggers an inflammatory response.
And what are the common triggers for these flares?
They can be surprisingly mild. Things like emotional or physical stress, the menstrual cycle, pregnancy, local mucosal trauma in PFIPA, or even cold exposure, as you see in some cryopyrin-associated periodic syndromes. Critically, vaccination reactions are known to trigger marked flares, especially in hyper-IgD syndrome.
Let's look at the genetic basis for these specific syndromes.
Familial Mediterranean fever, or FMF, is caused by a mutation in the MEFE gene, which affects the pyrin protein. FMF is characterized by attacks of fever, abdominal or chest pain, and arthritis, and it is also known to cause sensorineural hearing loss.
Next, hyper-IgD syndrome.
HIDS is linked to the MVK gene, which leads to mevalonate kinase deficiency. Patients have high levels of immunoglobulin D, frequent fevers, lymphadenopathy, and a unique sensitivity to immunizations as a trigger.
And tumor necrosis factor receptor-associated periodic syndrome, or TREP.
TRPS involves a mutation in the TNFRSF1A gene affecting the TNF receptor type 1 protein. The flares often last longer, sometimes for weeks, and can be associated with migratory skin rashes.
Now, the cryopyrin-associated periodic syndromes, or CKPS, these are all linked by a common genetic mutation but have varying severity.
All CAPS are linked to the NLRP3 gene mutation, which affects the cryopyrin protein. This gene is the primary regulator of the interleukin-1 pathway. The phenotypes range in severity. Muckle-Wells syndrome presents with conjunctivitis, recurrent urticaria, a hive-like rash, and progressive hearing loss in about 1/3 of patients.
And the most severe form often starting very early in life.
That is chronic infantile neurologic cutaneous articular syndrome, or CINTIA, also known as neonatal onset multi-system inflammatory disease, or NOMID. The onset is often neonatal. Features include daily fevers, a measles-like macular rash that can easily be confused with systemic JIA, lymphadenopathy, splenomegaly, and most significantly, sensorineural deafness and CNS involvement.
And there's a pathognomonic bony feature, right?
Yes, the structural sign that confirms tincanemia is the patellar overgrowth, an enlargement of the kneecaps. This is one of the clearest clinical signs of this severe systemic disorder. The neurological and ocular complications like optic neuritis are serious, but early IL-1 targeted treatment can prevent permanent brain damage and learning difficulties.
That brings us to the targeted therapy for these conditions.
Because all CKPS syndromes are 100% interleukin-1 driven, the response to specific IL-1 blockers is dramatic. Anakinra and canakinumab, which block the interleukin-1 pathway, are standard therapy.
What about the adult-onset CAPS variant?
That is Schnitzler syndrome. It's a late-onset, non-familial CKPS-like disorder diagnosed in adults. It's characterized by chronic urticarial rashes, intermittent fever, joint pain, and an IgM gammopathy.
And it's also IL-1 driven.
Like CKPS, it is completely IL-1 driven and shows a near-perfect response to anakinra. The long-term risk here is progression to Waldenstrom's macroglobulinemia.
And finally, PFAPA syndrome, the most common recurrent fever syndrome in children.
PPAP is unique because, despite its clinical similarity, no identifiable gene has been found. This makes the diagnosis entirely clinical recurrent fever, apellis ulcers, pharyngitis, and adenitis. It accounts for about 50% of all recurrent fever syndromes in childhood and, interestingly, often responds completely to tonsillectomy, though attacks can occur frequently for up to a decade before they spontaneously resolve.
Let's transition to sarcoidosis and its counterpart, Blau syndrome. What is the hallmark of sarcoidosis?
Sarcoidosis is a systemic disorder defined by the formation of non-caseating granulomata-organized clumps of inflammatory cells that do not undergo caseous necrosis in multiple organs.
And how does this specific pathology present in the ENT tract?
The granulomas can deposit anywhere. We see chronic sinonasal disease, nasal perforation, laryngeal disease leading to hoarseness or vocal cord deposits. Neurological involvement often manifests as trigeminal or facial nerve pain. We also frequently find solitary or bilateral parotid gland enlargement.
And our source provided a highly specific visual clue for nasal sarcoidosis.
Yes, upon nasal endoscopy, the mucosa of a patient with sinonasal sarcoidosis has a characteristic appearance that clinicians refer to as apple jelly nodules. They are small, glistening, yellowish-red nodules. Recognizing this visual pattern is critical, as a biopsy of those nodules will confirm the non-caseating granulomas.
If sarcoidosis is suspected, what systemic screening is mandatory?
A chest X-ray is essential to check for hilar lymphadenopathy or pulmonary infiltrates, which are hallmark findings. We must also run a urinalysis to screen for proteinuria or hematuria, indicating rare but serious renal involvement.
And the eyes.
And finally, every patient requires an ophthalmological review to check for subclinical uveitis, which is common and can cause permanent vision damage if it's missed.
What about Blau syndrome?
We should briefly note Blau syndrome, which is genetically linked via CARD15A-NO-D2 mutations. It is clinically very similar to young-onset sarcoidosis, often presenting with a triad of polyarticular arthritis, eye inflammation, and a rash.
We have established the diagnostic framework. Now we pivot to management and risk because treating these high morbidity diseases introduces a whole new set of clinical challenges.
That's right, we have to manage the dual risk. The underlying rheumatic condition is often immunosuppressive by its nature, and the required treatments, steroids, and disease-modifying anti-rheumatic drugs, or DMARDs, compound that risk.
Making these patients highly susceptible to serious infections. So immunization is not optional, it's mandatory.
Absolutely. Immunizations against the flu, pneumococcus, and any killed vaccines are safe and strongly recommended to reduce the infectious burden. However, clinicians need to time the administration appropriately, as the efficacy of the vaccine may be reduced if it's given during a period of intense immunosuppressive drug treatment.
Let's detail the pharmacological arsenal. What are the traditional foundational treatments we rely on?
Steroids, or corticosteroids, remain the rapid first line for controlling acute, severe flares. DMARDs are the standard long-term agents. Methotrexate, cyclosporin, azathioprine, and leflunomide. For severe or rapidly destructive vasculitis like GWP, we turn to cyclophosphamide, which is a powerful cytotoxic agent.
The revolution in the field has been the development of biologic therapies. How do these targeted agents fundamentally change the treatment strategy?
Biologics allow us to block specific inflammatory pathways rather than relying on broad-spectrum immunosuppression. For instance, we use anti-tumor necrosis factor, or anti-TNF, blockers like etanercept, infliximab, and adalimumab. TNF is a key pro-inflammatory cytokine in diseases like rheumatoid arthritis and ankylosing spondylitis.
And for inflammation driven by other cytokines.
We use anti-interleukin-6 or anti-IL-6 blockers like tocilizumab, which is highly effective in systemic GIA and large vessel vasculitis. And crucially, as we discussed, for the autoinflammatory syndromes like CIPS and Schnitzler's, we rely on the anti-interleukin-1 or anti-IL-1 blockers, anakinra, canakinumab, and rilonacept. Blocking IL-1 stops the core mechanism of the disease.
What about therapies targeting the immune cells themselves, specifically B cells and T cells?
We use anti-B cell drugs like rituximab, which depletes B lymphocytes, and it's proven highly effective in ANCA-associated vasculitis and severe SLE. Belimumab also targets B-cell activation pathways. For T-cell modulation, we use the anti-costimulatory molecule blocker abatacept, which prevents the co-activation signal required for T-cells to fully launch an attack.
Any others?
We also use other modalities like immunomodulatory doses of intravenous immunoglobulin, or IVIG, and colchicine.
Now let's wrap up with what is perhaps the most crucial clinical knowledge for ENT specialists and anesthetists: the high-risk factors for intubation and airway management in this patient group. This is where the structural damage becomes an immediate threat.
There are 5 major factors that must be anticipated to prevent a catastrophic complication during airway management or surgery. First, arthritis of the temporomandibular joint, which, especially if it's coupled with decreased jaw growth, severely limits mouth opening. This makes mask ventilation and laryngoscopy extremely difficult.
Second, the high-risk joint we discussed earlier.
The arthritis of the crico-arytenoid joint. If there is pre-existing inflammation or limited movement, the risk of an acute airway emergency or an inability to pass the tube increases exponentially. This requires a high degree of preparedness, often including fiber optic intubation techniques.
Third, the cervical spine instability.
Arthritis of the cervical spine, particularly in advanced rheumatoid arthritis or JIA, can cause atlantoaxial subluxation instability between the first 2 cervical vertebrae. Any excessive neck movement during intubation poses a significant risk of severe spinal cord injury. Neck stability must be assessed preoperatively.
And what are the risks stemming from the diseased tissue itself?
Fourth, disorders that cause tracheal stenosis, like late-stage granulomatosis with polyangiitis or relapsing polychondritis. The narrowed, scarred airway poses an obvious intubation risk. And fifth, systemic sclerosis patients. Their tight, fibrotic soft tissues, combined with the decreased mouth opening, present a classically difficult airway scenario.
And finally, we have to revisit the concept of the masquerade, but this time emphasizing the distinction between autoimmunity and malignancy.
This is the ultimate diagnostic warning. Lymphomas and leukemias can present with features that are highly suggestive of autoimmune disease, including fevers, joint pain, and even raised autoantibodies. This is known as an EBI phenomenon.
So the systems can overlap completely.
They can. So if a patient presents with persistent lymphadenopathy, systemic symptoms, or symptoms that fail to respond to standard immunosuppression, the necessity of obtaining a tissue diagnosis to rule out malignancy cannot be overstated. The ENT specialist, seeing chronic head and neck symptoms, has to maintain a high index of suspicion for cancer and avoid a dangerous misdiagnosis.
Well, we've completed a truly comprehensive journey today, moving from the localized symptom right up through the systemic red flags, the complex classification criteria of SLE, the size-based categorization of vasculitis, and the genetic mechanisms of autoinflammatory disease.
We've established that the ability to synthesize these disparate pieces of information, connecting that painless oral ulcer to anti-dsDNA, or the ear cartilage inflammation to the potential for tracheal collapse, is the essence of specialist diagnosis in these high morbidity conditions. Pattern recognition truly does save lives.
So what does this all mean for the future? Our sources point toward crucial areas needing further exploration in this intersection between ENT and rheumatology. We need long-term outcome studies of childhood ENT diseases, especially conditions like GWP, where early laryngeal stenosis has lifelong implications.
And more provocatively, we need clinical trials focusing on the efficacy of early aggressive treatment of isolated ENT autoimmune disease. If we catch a disease like GWP or relapsing polychondritis when it's confined only to the nose or the ear, can we prevent the generalization?
Can treating the nasal lesion prevent the subsequent kidney failure?
Exactly. Can it prevent the kidney failure that defines a generalized deadly disease? That is the cutting edge of prevention.
It means the answer is often right under the nose, or perhaps right in the vocal cord. Apply this new, comprehensive knowledge to elevate your clinical thinking and look for the connections. Thank you for joining us for the deep dive.